Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Preventing and Managing Toxicities Associated with Antibody-Drug Conjugates in the Management of Metastatic Breast Cancer. We have a great faculty today, Dr. Lisa A Carey from the Lineberger Comprehensive Cancer Center at the University of North Carolina in Chapel Hill, North Carolina, and Dr. Rita Nanda from the University of Chicago in Chicago, Illinois. Today we're here to talk about the management of metastatic breast cancer, particularly the use of ADCs. As always, we will be getting into the use of unapproved agents and regimens, so check out the official prescribing information for these products for more. As we've been doing quite a bit now since the pandemic, including last night in gastroesophageal cancer, we asked some general medical oncologists and community-based practice to present cases to you all today. So part of what we're going to do is make rounds with these docs on metastatic breast cancer, particularly related to the use of ADCs. Here's where we're heading. I want to start out with a few overview comments, and then we'll get into some cases. And in between the cases, we'll take a look at some of the data. But actually, faculty, when we first wrote the grant, every webinar we do, we write a grant. And when we first wrote this grant, I guess last year, we had no idea that by the time we got to this, in the previous few months, there'd be 7 phase 3 randomized trials presented between ASCO and ESMO. Sort of amazing, and just a part of breast cancer. There's so much going on, ER positive, et cetera. So we have to get a little bit into what the data was presented there. We're going to pick it back up in San Antonio as well. So we're going to talk about toxicity, but we're going to emphasize also these 7 trials, the toxicity findings there, and of course the many, many questions we're getting about that. So before we sort of blast into this and start talking about taking care of patients, I want to take a deep translational breath. And Lisa, I always love the symposia where you focus on biology of ADCs, how they work. You have the antibody, the payload, and the linker. I'm just curious, there are a couple of slides from ESMO actually looking at theoretical mechanisms of toxicity, which was, again, what we're going to emphasize today. Can you talk a little bit about how you think this through, Lisa, in terms of toxic effects that are related to the antibody, to the payload, to the linker, how you think about that?
Oh, absolutely. You just have to keep remembering that these are Lego sets, right? Like you're attaching things to each other. And, the mechanisms of toxicity and frankly, the mechanisms of resistance can relate to any of the pieces of this construct. So, this is a nice figure on the left. You can see, the A part of an ADC, of course, is an antibody, and the antibody can be TROP2 or it can be HER2 or it can be a variety of other things. And, so you can have toxicity based on the nature of the antibody. And a great example, of course, is, HER2-based antibody, particularly in a patient who's never received an anti-HER2 drug before, you can have cardiotoxicity, right? Just because it's an anti-HER2 antibody. There's also the opportunity for there to be immune activation that these things can stimulate. And so that can sometimes create toxicity. It's also part of the efficacy, almost certainly. Conversely, at the other end of it, you've got the payload. So they're all attached to something. And in all of our, all 7 of the Bonanza articles, they're all, at the moment, cytotoxic. So we've taken this opportunity to attach a chemotherapy drug to an antibody. What's coming are a bunch of other payloads that presumably will have different toxicities, also different efficacies, and maybe even more interesting. But at the moment, you have to remember that what you're delivering is usually a topoisomerase inhibitor, that's the majority of them, or a microtubule inhibitor in the case of, say, TDM1, et cetera. And so you have the toxicity of those kinds of chemotherapy drugs. And remember, part of the reason for creating ADCs was to minimize the kind of toxicity you see if you give these drugs as free agents. But you don't totally eliminate it, and you're still going to get chemotherapy-type toxicity.
So, Rita, anything you want to add to that? And also, any comments about sequencing ADCs? This is probably the number one question from general medical oncologists. Hear people saying, well, you don't want to do 2 ADCs in a row or do 2 ADCs that have the same payload, put regular chemotherapy in between, whatever. Any thoughts about how these things are constructed and the biology affecting the way you sequence, and any other comments about the mechanism of toxicity.
Yeah. I mean, I think when we think about the toxicity from ADCs, it's largely related to the payload, right? I mean, absolutely, we can have antibody toxicities, as Lisa just mentioned, notably with the HER2 antibodies, the monoclonal antibodies. We've definitely seen that. Pertuzumab, we've seen a lot of diarrhea with that monoclonal antibody. So absolutely. But I think when I think about a lot of these ADCs, a lot of the side effects we see are largely payload related. But I have to say, what I find fascinating is that you can have two TROP2 targeting ADCs with a similar toxic payload, albeit different drugs, but they're both topoisomerase 1 inhibitors. You can see a very different side effect profile. So, there's definitely a lot that we have yet to really understand and tease out about that. In terms of sequencing, that is, the question that's out there that is top of mind for everyone. We've seen so many trials, as you've pointed out in the last year, these large randomized, phase 3 trials that have over and over and over shown us again that these ADCs are more effective than traditional chemotherapy. And so it's, the issues have been, however, all of these trials, at least the trials that led to the initial approvals for the ADCs, didn't have patients who'd had another ADC prior to enrollment. So that's the issue of sequencing. We don't have great data on sequencing. And most of what we've seen to date are registry studies, retrospective data sets. And what we've seen in those are when we sequence ADCs, we generally never get as much efficacy out of the second ADC as we would have expected had they never received an ADC before. And that's led people to think about sandwiching. Should we do one ADC and then maybe a traditional chemo and another ADC after that to give patients a break? Expecting that it could very well be payload resistance that's leading to why, one ADC doesn't work after another. And I think we just don't have the answer to that question. There are randomized studies ongoing looking at ADC after ADC, but I think what's very clear is that we know payload resistance is a big part of resistance to an antibody-drug conjugate. After patients have been exposed to a similar payload in the past. And so we just need ADCs with different payloads. And that, I think, will really help us. So we'll see a whole slew of trials coming down the line with ADCs, maybe with different antibodies, targeting different antigens and different payloads that have different mechanisms of action than the 3 that we've got now that are FDA approved, which are all topoisomerase 1 inhibitor payloads.
And then here's where we're heading over the next few minutes in terms of the cases we're going to present and some data slides we're going to show. Interesting, you were talking about the 2 TROP2 ADCs currently approved in breast cancer, sacituzumab and Dato-DXd. And actually, there's a third one now that's one of those 7 phase 3 trials, SAC-TMT. So I'm real curious to see. Most people in the U.S. haven't used SAC-TMT, where that's going to fit in terms of toxicity. But let's get into the clinic here. We're going to start out, certainly I think one of the biggest stories of the year in breast cancer has been the evolution very rapidly of the use of ADC plus IO in the first line setting. We saw the ASCENT-04 trial at ASCO looking at sacituzumab and pembro, and then at ESMO, ASCENT-03 looking at sacituzumab without pembro and people without PD-1 levels, but also trial looking at Dato in the first-line setting, again, without checkpoint inhibitors. But Dr. Zelkowicz has an interesting question. Certainly one of the questions I've been hearing a lot about use of IO and ADC is, what about the patient who has a prior history of receiving an IO, KEYNOTE 522 in the neoadjuvant setting? Are you going to bring back an IO in the metastatic setting? But here's another situation that happened with Dr. Zelkowicz's patients that maybe I didn't think so much about, but I think also brings this whole thing into question. Here's the case of a 68-year-old woman.
Very locally advanced cancer, biopsied, and ER0, PR0, HER2-0. She got classic KEYNOTE, and very shortly after starting the AC developed either myocarditis or decrease in conjecture fracture. So we stopped the adriamycin and we stopped the pembro. Interestingly enough, she went to the operating room. She had just residual DCIS. received her PMRT, did not continue on Pembro because of the possibility of myocarditis.
I see she presented 2 years later with fulminant metastatic disease, including pleural effusions.
Presented sick, not unusual for a triple negative, with lots of shortness of breath, to a neighboring hospital, had a CAT scan, very suspicious for lung metastasis. She had a PET scan, bone and adrenal disease confirmed, brain was negative, ER0, PR0, HER2 0, PDL positive. Again, she was sick. I started her on SASI, and her repeat echo was 49%. She just began her second cycle. She actually is feeling better already. I guess the real big question is, with ejection fraction of 49, pending the input of the cardio-oncologist, would anybody re-challenge her with pembrolizumab, given the interval and that she's PDL positive?
So, Rita, any thoughts about this case?
Yeah. No, I mean, I think that's a great question. So as you noted, Neil, ASCENT-04 was a positive trial. So adding pembrolizumab to sacituzumab govitecan for PD-L1 positive triple negative breast cancer did improve progression-free survival. And that trial did allow patients who'd had prior IO, but it was just a handful of patients who'd had prior pembrolizumab, just based on when that trial was conducted. And so, too small of a number to really get a sense of whether or not there's a benefit in patients who've had previous pembrolizumab. I think, this is a 68-year-old woman, now presumably 70, or maybe she was 66 when she was first diagnosed. It's hard to know if that decline in ejection fraction back then in the early stage setting was adriamycin, or doxorubicin potentially, or pembrolizumab. And, I think in the metastatic setting, it could be considered with very close monitoring to try to re-challenge her. And if there are any issues, then, obviously you can incorporate steroids and things like that. But, most of the myocarditis cases that I think have been seen, and I've not personally seen a case myself, are usually fatal. And so I just wonder if some of this decline in ejection fraction back then was more the anthracycline than the pembro. But impossible to know. It's reasonable to consider, with a conversation with the patient to add pembro, but again, with very close monitoring in conjunction with a cardiologist.
So, Lisa, before you make a comment about this case, I just want to bring up, so I brought this up to you both in the rehearsal, and the audience is very familiar. A lot of our audience attends all our webinars. What's happened over the last couple of weeks, that last week we saw a slide looking at small cell, extensive small cell, suggesting that now in the era of adding IO to chemotherapy, they're seeing 10 or 12% 5-year survival, which is like shocking. You never even think about it. You think you're in a palliative situation. And the idea that maybe you might see long-term survival, a lot of times will change how much risk you're willing to take. It sounds kind of scary to give an IO to somebody who has a history of cardiac problems. But Lisa, I was asking both of you ahead of time, sort of the small cell question. What's the 5-year survival roughly of metastatic? I'm not saying, if you ask ChatGPT, it'll probably say a lot less than what you might say. But what would you say to a patient who says, overall, what's the chance of surviving 5 years if you're a metastatic triple negative, who PD-1 negative, and you never get an IO, and PD-1 positive? Do you see people who survive 5 years?
I do. I mean, we all do. And I've seen patients who never saw an IO who have survived, many, many years. And I've seen, I would say, more patients surviving many years who did have the benefit of an IO. So I think we're entering into a new world. We haven't done it as fast with triple negative as we have with any of the other subtypes of breast cancer, but I do think we're starting to see those survival curves bumping out. And I do think you can attribute some of that to the benefit of ICIs. What I don't know is what's going to happen in the post-IO, patients who relapsed in spite of that given in the early setting. None of us know that. I think Rita just outlined that very well.
Lisa, what about the issue of the patient who develops immune toxicity with an IO in the localized setting like this patient maybe did? But there are many other types of toxicity, pneumonitis, colitis, etc. What kind of toxicity in the localized setting, Lisa, would get you to really not use an IO on recurrence, if any?
If it's really life-threatening and pretty clear related to the IO, then I would hesitate. I agree with Rita. This particular case, I probably would blame the anthracycline. It's not clearly myocarditis. And our own data suggests that, from our multidisciplinary team that's been tracking this in a registry, that re-challenge after a toxicity with co-management, and that's a key part of this, they see about a third that have enough of a symptomatic re-flare that they have to stop, but many don't. And I think, these can sometimes be managed effectively. You do have to have very balanced conversations, and I wouldn't do it in certain circumstances where it was really life-threatening the first go-round.
So I want to bring up four of those 7 trials that we just talked about. And again, we're not going to do an A to Z discussion. It's just sort of a tasting menu type thing, and we'll see more in a couple weeks. But and you can go through, the slides are all in the chat room if you want to take a closer look at them. But I really just want you to talk a little bit more about the main findings, and particularly the toxicity issues that we might want to anticipate. So Rita, let's start out with the ASCENT-03 study. This was presented at the ESMO meeting. It was kind of the companion to the ASCENT-04 study. Triple negative, but people who are not able to get mostly PD-1 negative patients. As we saw, seen it in a press release, this was a positive study. You did see a PFS advantage with a hazard rate of 0.62. And I'm curious, and I think the safety issues were kind of what you would expect from previous use of SG, although now here we're using it in an earlier setting. Rita, anything you want to say about the toxicities in general that you kind of think about with SG and what was seen here in the ASCENT-03 study in terms of the type and intensity of toxicities?
Yeah, nothing new, as you just mentioned, Neil, from what we would have expected based on ASCENT and other studies. Neutropenia and diarrhea are kind of the two big things, which we would expect with a antibody-drug conjugate that's got SN38, the active metabolite of irinotecan, as the payload. And I will say, I haven't used irinotecan in years, but I think SG is easier to tolerate than irinotecan from what I remember back many years ago. And so, again, I think that, based on some data in bladder cancer where they saw some neutropenic deaths, the label for SASI has changed to now include potential consideration of prophylactic growth factor. I will say I don't generally do that in my practice. I have a low threshold for adding it in if need be. But, something that could be considered in patients maybe who have had challenges with cytopenias in the past. But again, nothing new here, nothing unexpected. I think that for the most part, these toxicities are manageable. The diarrhea and the neutropenia with growth factor, with antidiarrheal agents or dose reductions.
Incidentally, in the chat room, Danny says, quote, I believe IO myocarditis is usually part of a triad of polymyositis and myasthenia gravis. He says the absence or the other two components makes me think this is from the doxorubicin. I don't know. Interesting thought. Anyhow, Lisa, we're going to see another phase 3 trial at the San Antonio meeting. There's a press release out saying this is not going to have met its endpoint. But now we're going to be looking at first-line therapy in ER positive. We also already have an established role and approval of sacituzumab in the second-line setting. But Lisa, of course, the other big SASI first-line trial that we saw was at ASCO. At ESMO, we saw some patient-reported outcomes. This is a so-called ASCENT-04 study. Now looking at sacituzumab with pembrolizumab versus chemotherapy with pembrolizumab. And again, the theme that we see, not just in breast cancer, but it seems like on most of the ADC trials in general, that ADCs generally often will work better than traditional chemotherapy. in terms of they presented some quality of life. But again, Lisa, any thoughts about how you're adapting the ASCENT-04 study? Is that your first-line therapy right now in patients with positive PD-1? And any toxicity issues of using the combination? Theoretically, you could get diarrhea from each one. Any toxicity issues you want to comment on from this study?
Yeah, well, I think the toxicity profile, just as Rita just said, the toxicity profile seen in ASCENT-04 is essentially what you would expect with sacituzumab and with pembrolizumab. And I don't think there were any, incredible surprises in this. And it is more effective than straight up chemotherapy. And it's hard to do a comparison because, again, TPC, is a mixture of things. So you're not really comparing, I always ignore when there's a variety of drugs thrown into the proportion things, because you're mixing in taxanes and CAPE and all sorts of things. So, but if you just look on the right-hand side, you can see, neutropenia and diarrhea. And there was a study called PRIMED that was, I can't remember if it was published or presented, but, it's kind of like the dose escalation and prophylactic approach to small molecule inhibitors, which was, to try and get ahead of it. I think SASI, I generally have used secondary prophylaxis, but I've recently had a couple of bad experiences with early neutropenia that ended up being pretty serious. And in the PRIMED study, it was interesting that, prophylactic loperamide and growth factors did seem to have, a significant impact. I think, we have to be very, very vigilant with this drug about managing the toxicity, because one of two things can happen. Either a serious toxicity occurs or the patients have a lower grade toxicity, but their quality of life is impacted significantly. And, this is all about quality of life in addition to efficacy.
So this is kind of a cool slide from several studies comparing PRIMED, where they use preemptive antidiarrheals and growth factors, and that's in the gray bar. And the other two, the red and blue, are prior studies where they didn't necessarily use any preventives. So I'm just curious, Lisa, do you use either preventive antidiarrheals or growth factors to start with, or you wait and see?
I have not. I have typically had a low threshold, but I haven't used them prophylactically.
So you were mentioning, Rita, how different the side effect profile is of these two TROP2 ADCs, and here it is. We see Dato-DXd, again, in metastatic triple negative, where immunotherapy, so comparable to ASCENT-03. And in terms of efficacy, again, we see a DFS advantage here, hazard rate of 0.57. Survival, maybe, I don't think statistically significant or maybe premature at this point. But again, Rita, can you talk a little bit? Of course, we've seen a bunch of trials, also ER positive, where data is now approved. So we do have experience with this agent. Can you talk about what they saw here in this triple negative study and how that compares overall to what you have seen with Dato-DXd in terms of toxicity?
Yeah. So in TROPION-Breast02, there was actually a survival advantage. So that was exciting to see. I think it's important to note, though, there was very little crossover to an ADC subsequent to that in the patients who got chemotherapy. So, unlike ASCENT, where 80% of patients crossed over to SASI. So, kind of a little bit of a different when we're thinking about these trials and putting the efficacy into context. But for Dato, I have not used it in the metastatic setting, but I have used it in the early stage setting as part of a neoadjuvant trial. And I have to say that the side effects here are so distinct from SG, where we see, neutropenia and diarrhea. Here with Dato, we're seeing mucositis, we're seeing eye toxicity. And, we learned very early on in our neoadjuvant study that we need to use prophylactic steroid mouthwash and prophylactic eye drops and prophylactic eye drops that are moisturizing, steroids and moisturizing 4 times a day. So that is an extra thing that needs to be done. Despite that, you will see dry eyes, you will see some mucositis, stomatitis in these patients. But those are, very distinct side effects there.
So we'll get into that too as we talk about some of the cases and the questions from the docs. But just one final phase 3 triple negative study, or actually, wait a minute, this is hormone ER positive metastatic. Yeah, and I'm sorry I got the survival thing messed up there, but the lack of crossover. It says this is like kind of the Talmud trying to keep track of all this stuff here. So, I've heard people say SAC-TMT, Lisa's kind of toxicity is kind of in the middle between Dato and SASI. I don't know exactly what it means. I don't know that you've used it. It's developed in Asia. What do we know about toxicity?
Well, I think, it does bring up, many of the same, there's some eye toxicity, maybe not quite as much as with Dato-DXd. There's, I think, as much stomatitis as there is with Dato-DXd. And then the rest of the things are, more or less as expected. What it doesn't have is ILD, not to a significant degree, which is nice. And then otherwise you see similar, it is, again, a topo-1 inhibitor attached to a TROP2. You see the typical chemotherapy topo-1 inhibitor side effects. So I think, to my mind, the big distinguishing feature is really sacituzumab govitecan versus the other two with these unusual side effects, which I do think, as Rita noted, you really have to be actively managing them. And frankly, I always categorize toxicities as the things that I have to pay attention to, but the patient doesn't know about, and the things that they're going to tell me about. And I'm much more worried about the things that they're going to tell me about and that are really interfering with their quality of life. I'm a lot less worried about, minor league thrombocytopenia that doesn't end up being much of anything.
All right, well, let's get into a few cases and back to the real world here. And we were talking about the possibility that a patient with metastatic breast cancer, particularly triple negative, as opposed to HER2 positive and ER positive, where you can see long-term survivals. Here's a case where this actually happened. Really interesting history, so to speak. I'm curious what your thoughts are about it. A 74-year-old lady who has a recurrent ER negative, HER2 low, PD-L1 positive metastatic disease.
She had progression of disease. And at that time, in August of 2020, I started her on sacituzumab. She had excellent response. Her liver metastasis is resolved completely. Her tumor marker normalized. She developed fatigue, nausea, diarrhea. And then in 2023 said, if my scans are showing no evidence of disease, can I just go off the medication? So I said, yeah, we could do it, understanding that this disease could come back. And then a year and a half later, she developed recurrence in the liver. And we restarted sacituzumab with 10% dose reduction. She's doing very well. And she's responding. She had her scan done in May, which shows a nice response to sacituzumab. My question here is, if this patient progresses, what would be your next line of treatment? She is HER2 low, so her HER2 was 2+ and FISH negative. Would they switch her to TXD? What is the role of Dato-DXd after patients have received sacituzumab or they have received trastuzumab deruxtecan?
What was her quality of life like when she first started the sacituzumab?
Mild diarrhea, she very well managed. Neil, I have to be honest, in my hands, sacituzumab, I thought they do very well. I never had to stop any patients from getting sacituzumab. I would like to ask the faculty if they have seen that the response of the patients to sacituzumab is different based upon the TROP2 expression. I know there is an assay in lung cancer.
So, Rita, sounds like a prostate cancer, intermittent endocrine therapy here. Give it for 3 years and wait, and then they come back. I'm really not expecting that. Any thoughts about the case? And also this issue of TROP2 levels. There's some data actually in lung cancer. I think it's with Dato that maybe there's a membrane cytoplasmic assay they do. Any thoughts about this case? Have you ever stopped sacituzumab in the metastatic setting like this?
Yeah, I mean, I've certainly given patients chemotherapy holidays if they've got a trip or a vacation or they're getting a little beat up. But Probably not for this length of time. I have definitely had patients respond exceptionally well for a very long time. I mean, I actually had a patient who was on a scent who was on the therapy like for 4 years. They completed therapy, they did a rollover, and then they said, can you just give this patient commercial drug now because it's been out there and approved for years. So you definitely see these exceptional responders to SASE, and it's great to see. It's great that she's responding again, because that's certainly not always the case, right? You might expect that what's left behind might be resistant, and so there's no guarantee. So that's really exciting to think about. And, I don't fault the Dr. Gupta for doing this. I mean, this is a 74-year-old lady. She wants some time off, and she probably had a nice run of kind of an interval of being off of chemotherapy and some of those side effects. What to do at the time of disease progression. I think as we've mentioned earlier, we don't have great data about sequencing. I think it's reasonable to consider TDXD next. It's a different antigen target, or it could be traditional chemotherapy. This is a patient who's got a little bit more of an indolent triple negative breast cancer. You could even consider something like capecitabine, maybe to give her a little break off of some IV treatment, and that certainly wouldn't be wrong either. I think it's all a discussion with the patient, and probably a sense of how aggressive is the progression. Is it, disease exploding and you've only got one more shot at trying to offer the patient therapy? I'd probably favor TDXD. If it's a little bit of progression and maybe moving on, I might consider something like capecitabine or eribulin even.
So, Lisa, any thoughts or comments? And also any comments on her TROP2 assays? Are we ever going to be looking at that?
So a couple of things. TROP2 assays do look like there is some dose-response relationship, but it's not clean enough where you would choose not to use it at any particular level. And I think that's where the rubber hits the road. All I would say is I probably wouldn't use Dato-DXd in this setting, right? Because you want to change as many things as you can if you're going to give another ADC. And then I'll just give a shout out to Dr. Nanda's own trial. She and Tiffany Traynor of Memorial Sloan Kettering are running a trial looking at an AR targeted agent in this setting in patients that are AR positive. So I think we're hoping for some non-chemotherapy options in the future.
Yeah, I'm waiting for that. We hear about that for years and years, and hopefully it'll come. That's so interesting, so fascinating. All right, here's another great case. So has a very interesting beginning and a very, to me, unexpected ending when I heard the end of this case. So faculty consider an 83-year-old lady, ER positive, HER2 low disease, who's gotten TDXD and now is progressing, and goes to Dato-DXd, something you all just said maybe you don't generally do, and starts to develop pulmonary symptoms. So your mind starts racing, but here's actually what happened.
After about 3 cycles, she developed a severe cough. She was evaluated, and a CT scan showed an area of ground glass opacity that the radiology report noted was concerning for a treatment-related pneumonitis. Part of her workup did include a viral panel that was positive for a viral infection as well. So we did treat her, symptomatically. We did initiate steroids. She ultimately was seen by a pulmonologist, and a repeat CT scan was done. At that point, thankfully, the changes had resolved, and this was attributed not to drug-induced pneumonitis, but to a viral infection. And she's improved, and we've reinitiated Dato-DXd without any further respiratory symptoms.
Wow. And she's still on the Dato?
She is.
When she had the pneumonitis, did she have a fever or anything suggesting infection?
She did. She had fever, malaise, and a cough.
Huh. Wow. How high was her temp?
It wasn't too high. It was 101. Can you discuss the risk of pneumonitis with ADCs, specifically this newer agent? What is your typical approach for evaluating and diagnosing pneumonitis that might be related to a cancer treatment?
Did she have any mucositis at all? Did she have any issues with her eyes?
No, she did not.
So, Lisa, as soon as I heard this case, I'm like, I can't wait to present this. This is really amazing. I'm curious what your thoughts are about this case and your experience, dealing with pulmonary issues that develop, people get infections, et cetera. Any thoughts about this case? Any that you want to comment on, Lisa?
Yeah, a couple things. I mean, I think if you're going to go ADC to ADC, this isn't an unreasonable direction to go, right? You have an anti-HER2 one and you went to a TROP2 directed one. So you're changing up the antibody. Although, again, they both have topo-1 inhibitors, which we're really looking forward to non-topo-1 inhibitor payloads. I think, ILD is obviously greatest with TDXD, but it absolutely happens with the other ones. And I think in the Tropion breast studies, it was not 5%, but it wasn't none either. And so, and I think that, you do need to remain vigilant for these drugs and any kind of, drug-induced pneumonitis. But I think this is such a wonderful illustration that, patients can still get like normal diseases that aren't related to the drugs we're giving them. And we have to, keep being attentive to that. Otherwise, you stop a drug that is working, for a reason that isn't valid. And I actually think this is a terrific example of that.
So, Rita, any thoughts about this case? A lot of drugs can cause ILD. One of the things I think I'm seeing is definitely with Dato, is applying the management of ILD that was developed from TDXD to other ILD from other, I don't know whether you would do it with a patient who gets ILD from an oral agent. I think you can get it from CDK or, other agents. But this idea of, holding for trying to diagnose grade 1, holding, using steroids and maybe retreating, thinking seriously or not re-challenging if they're going to be grade 2. But in general, do you think that the risk of ILD with Dato is closer to, sort of the typical drugs we use or more towards TDXD? I've heard people say that there are a lot of HER2 receptors in the lung, and maybe that's why you see more ILD with TDXD. What are your thoughts, Lisa?
Lisa or Rita?
Lisa. Sorry, did I say Rita before?
No,
whatever.
You're going down the Rita direction.
It's like a ping pong. It's like whack-a-mole.
Right, absolutely. I think, I think that's absolutely true. We do see it more with TDXD and but we don't see a lot of it with trastuzumab alone, right? So if you think about it, we all in the early days of trastuzumab, we saw, the occasional one, but not 10% or 10 to 15% like we see with TDXD. So there's clearly a part of it that is the combination probably of the antibody and the fact that there's a cleavable linker and there's getting a lot of DXD floating around in the milieu. I do think, the very high degree of prophylaxis or early detection, is a better term, that we use for TDXD, which is totally appropriate because remember all the grade 5 AEs that were seen in the early studies. If you don't pick it up early, you can get into real trouble. I don't know that we need to adopt that with every ADC. In fact, I don't. I think it's really a TDXD function. And remember, the risk is so much lower with the other ones.
So I want to actually get into TDXD, at least a little bit, or at least from a toxicity point of view. There's so many data slides to take a look at from the TDXD trials, so we're going to do that. But just a couple of quick things before we get to the next case. Instead of doing an algorithm, Rita, we put together a couple slides just looking at possibilities. So I'm curious how you think about sequencing with ER-positive, HER2-negative, or HER2-low metastatic breast cancer after patients are now resistant to endocrine therapy. So on ER-positive, HER2-low, obviously you have TDXD and the two TROP2 ADCs to choose from. You have capecitabine, other chemotherapy. For the rare or vanishingly rare ER-positive HER2-0 case, you've got, again, the two ADCs and other chemotherapy. People think about the performance status, tumor-related symptoms. Does the patient need a response? Rita, can you kind of globally talk about how you think through sequencing with ER-positive disease?
Yeah. No, I mean, and I think this is a really important question. It comes up in my clinical practice all the time, right? You have patients and they've progressed on their endocrine-based therapy. A lot of things that I take into account as I decide what am I going to use in that frontline chemotherapy setting is how long were they on their endocrine-based therapy? Were they on a CDK4/6 inhibitor and they just kind of blew through it? Or were they on it for years and years? How bulky is their disease? How symptomatic they are? All the things that you just talked about, Neil. I love to be able to offer patients capecitabine as their first line of chemotherapy for hormone receptor positive disease. I have had patients on capecitabine for years. 5 years. I mean, I have a patient right now who's been on it. And how great is that for her? Week on, week off dosing, really tolerable. She's not tied to the infusion suite. But, for those patients who are very symptomatic, they've progressed pretty rapidly. I don't know that if I'm going to necessarily get another line of therapy and they're HER2 low or HER2 ultra low, I'm looking to reach to TDXD for those patients. The HER2 zeros, I generally try some other chemotherapy, but will ultimately try to get TDXD for them if I can.
So it's going to be interesting. I'm looking forward to see what kind of therapies the control arm of the ASCENT trial 07 that's going to be presented at San Antonio, what they got, how many got capecitabine, et cetera. Anything you want to add to that, Lisa, in terms of ER positive? And we had the same kind of look at ER negative, but now here you have both not only HER2 low and HER2 negative, but also PD-1 positive or negative. And here in the PD-1 positive, you have the issue of IO, but all the other issues that we just talked about. And then in the PD-1 negative patients, you don't have the IO, but again, you still have in HER2 low, TDXD versus TROP2, and then the two TROP2s now that we have data studies as well. It'll be interesting. Lisa, how do you think through, I guess we could say triple negative, but HER2 low or HER2 negative cases?
Yeah, I'm laughing because the truth is that, as you say, it's a vanishing entity. The HER2 negatives, number one, it's kind of a silly assay that was never designed to be used the way it is. And now you're getting to the ultra low and you're getting to these, evidence that we really don't differentiate, into a group that does not respond to TDXD on the basis of HER2 immunostains. So I was laughing at Rita. It's like, I find a way, you find something that's stained, HER2 something, and your pathologist goes on a hunt. So I totally agree with the way she framed it. And I also have had patients on, with low burden, asymptomatic disease who have been on CAPE for a very long time. When you get to triple negative, you have a little less, time to play with, right? These patients, we had a case a little while ago that was relatively indolent, but many are not. And so I think, in the first line, you're really going to reach for a chemo-based option on the basis, with addition of ICI or IO on the basis of the PD-L1 status. And I think, we now have, evidence of the sacituzumab, with or without both being superior to a straight up cytotoxic. And I think that's the first pass. I do think that clinical factors, as you have on this slide, do play a big role, in terms of what kind of toxicity are patients willing to put up with, because we don't really know that if you were giving the same drugs and you just switch the sequence around, if it matters that much. Most patients are very interested in their first line going on as long as it can. And if you manage the side effects, them having a high quality of life, I think, that's probably what you reach for. But there's the occasional patient. In fact, I saw one today who really doesn't want any toxicity and does not want to spend much time with us. And she's on CAPE.
Yeah.
So I'm kind of curious, Rita, metastatic triple negative disease, HER2 low, what comes first, TDXD or sacituzumab?
I generally use SASI first in these patients. I think that while we have interesting, good data with TDXD, it was a subset of Destiny Breast 06, and we've got a large randomized phase 3 trial with ASCENT showing us substantial benefit with SASI. So I have a tendency to use SASI before TDXD.
All right, well, let's get back to cases. There's actually a patient with HER2 low but ER positive disease. Interestingly, had bladder metastasis. I'm curious whether you've seen that before. Progresses on palbociclib, then capivasertib and fulvestrant, then nab-paclitaxel. Here's Dr. Favreau.
She actually developed a bladder metastasis. She was having hematuria, and cystoscopy revealed a metastatic breast cancer to her bladder. She had about 5 or 6 months of control with nab-paclitaxel. She's HER2 1+, and so we tried TDXT, and I've given her 5 cycles of TDXT, and she's had a partial response, but now she's starting to progress on that. And so the question is, once she's had this drug and she's progressing on it, what's the next best step for her treatment? I'm looking at sacituzumab versus Dato-DXd.
What's your experience been with sacituzumab?
People do very well. There aren't a lot of side effects to it. You have to watch their counts. I usually give them the white blood cell growth factor after the day 8 treatment. So I'm really looking at using sacituzumab for her. Dato-DXd is, an option. There are ophthalmologic side effects of that, and there are also mucositis that goes along with that treatment.
I asked the faculty, how do you compare the tolerability of Dato and sacituzumab, and if they're equally effective? Thinking about it from the patient's point of view, which would lead the patient to have a better quality of life? If there's really a significant problem with mucositis, from my standpoint, that would be a very big negative, because eating is one of your major pleasures in life. If you can't eat, and you got pain, that's a big problem.
So, Lisa, have you seen hematuria and bladder mets from breast cancer? And any comments? We talked a little bit before about deciding. Now we have 2 approved ADCs or TROP2 ADCs. Dato being much more recent. And we talked to general oncologists. A lot of them they've had a lot of experience with SASI. They don't know much about Dato. A lot of questions about mucositis, like you just heard. They hear, if they do the prophylactic mouthwash, they don't have an issue. If they do get an issue, it's very hard to deal with. A lot of patients, won't necessarily do the mouthwash. So what's your clinical experience, and how do you decide with ER-positive disease whether you're going to use SASI or Dato?
Yeah, I think this gets right. Listen, they're both good drugs. They both work. I agree with Rita's earlier comment. You can't really put much on the survival outcome differential because one had a crossover and the other did not. And so, you've kind of, made that comparison no longer, a reasonable one. But I think, they both have, a significant prolongation in progression-free survival in a largely ADC naive population. So this is not that. But I think if you're choosing between them and whether you do a sandwich and then you decide or whether you go straight to it, I'm back to the, depends on what kind of toxicity is going to be the most bothersome to the patient. I think, they both have neutropenia. SASI has more, and that means I'm going to have to worry about that more. I think the diarrhea is more with SASI also, and you need to prophylax that. But I think patients, that what you have to do for the eye drops and the ice chips and the whatnot for Dato is, I think, troublesome. And they're going to need to come up with some very robust maneuvers, because those are the kind of things that bother patients. And they're on these things for chronic, they're on chronically as long as it's working. I don't know if Rita has a different thought than that.
Rita, also, I'm curious, we actually did a program this summer on ophthalmic issues with ADCs in oncology. If we finally found an ophthalmologist who could explain it to us, I hope Rugo found the doc from UCSF. It sounds like Dato maybe is not as much of a problem as, there's some other agents out there in ovarian cancer, mirvetuximab. Belantamab just got approved in myeloma. They really have major issues, but it doesn't sound like Dato is that much of an issue with the eyes. What have you seen? Do you even need to send them to an ophthalmologist to get started, or an optometrist?
Yeah, I primarily use Dato in the context of clinical trials. So an ophthalmologic evaluation prior to starting patients was something needed. And boy, is it really hard to get in to see an ophthalmologist. As someone who suffers from dry eyes unrelated to any therapy, I have to say I really feel for patients who have dry eyes, because by the end of the day, my eyes are always bothering me. I think Lisa touched on some really key points. Both of these drugs are good. They're both better than traditional chemotherapy. they have pros and cons, both of them. With SASE, we've got one set of side effects. With Dato, we've got another. SASE's 2 on, 1 off, Dato's once every 3 weeks. I think there are pros and cons to both therapies. And at the end of the day, it's a discussion with the patient. We've got these 2 great therapies, and how great is it to have 2 that we can discuss with patients? If somebody's got more of a challenge with diarrhea, like they've got inflammatory bowel disease or IBD or something, maybe I'm going to reach to Dato. Maybe if I'm worried more about, cytopenias, I'm going to reach to Dato. If somebody's like, I can't deal with the eye, the stomatitis, mucositis issues, because I agree eating is really important for patients with, any kind of cancer. But with metastatic disease, it's a really important part of maintaining good nutrition. And we can say, oh, it's only grade 1, toxicity that's been seen in the trial with these sort of aggressive, 4 times a day steroid mouthwashes. But I can tell you, if I get a mouth sore, I'm a big baby with just one sore in my mouth. And, it's hard to eat. And so I think we have to think about it from the patient's perspective as well. And, we write off a lot of grade 1 toxicity as tolerable, but at the end of the day, it really does impact quality of life.
So before we go to another case, Lisa, I can never resist a case that sounds like the doc might use some help here. This is what I call an elevator case. Imagine you're getting on the elevator at the 14th floor, and Jay in the chat room says, I have a 33-year-old lady who got Keynote 522 with good PR. She got CAPE Pembro adjuvantly, but relapsed within 2 months. Abnormal bili with obstruction. Originally HER2 2+, but biliary biopsy at the time of the stent says HER2 0. Stabilized with chemo, bili 1.5, quote, question mark, ADC next. If so, which one?
Well, I think this is so she had ICI, relapsed really quickly afterward. This is one of those great questions of let's assume she's PD-L1 positive just for the interest of conversation. Does adding Pembro when you're going to give a different chemotherapy partner with it still help? We do not know the answer to that. It's a subject of great debate and certainly of interest. I think, a patient who relapses early, I'm going to reach probably for an ADC. I mean, again, the SASE is the strongest group they've managed. It sounds like they've managed her bilirubin and the obstructive components so that she's, safe to give. Without, torching her LFTs. So I probably would do the same thing as I would do otherwise.
So I'm just going to fly through.
And if she's PD-L1 positive, I probably, if she's PD-L1 positive, you could make an argument for ongoing Pembro. But boy, if she was on it when it happened, I probably wouldn't.
Yeah, 2 months later is pretty quick. So again, a couple of weeks, we're going to go through all the new TDX trials, both the first-line DB09, as you see here, which of course was presented at ASCO, TDXD plus pertuzumab, looking really good. We'll also talk about the localized trials that were presented at the ESMO meeting, the use of TDXD in the neoadjuvant setting and in the post-neoadjuvant setting, both very positive trials. There's going to be a huge amount to sort through in terms of what people are going to do with the TDXD and HER2 positive breast cancer. We've been talking a lot about HER2 low, but of course, obviously, ADCs are very important of HER2 positive breast cancer. Just want to ask again, globally, without going through all the questions that come up about these trials, Rita, from a toxicity point of view, and here you see, for example, the Destiny Breast 05 toxicity. I don't think anything we weren't expecting in terms of actually this study comparing TDXD to TDM1, a lot, kind of what you would predict, I think. Anything about the toxicity of TDXD in these new settings, Rita, that you want to comment on? I guess using neoadjuvant TDXD is going to be new for people. It's a split regimen. Can you talk about some of the toxicity issues you think that are going to come up with TDXD moving forward?
Yeah. And I mean, I think this is very interesting because I think when we're talking about early stage curable disease, we don't want a fatal ILD, right? So I think that, that's been, I think, the main thought or concern as we're thinking about moving TDXD up into the early stage setting. Fortunately, patients in the study did quite well. But I also do want to emphasize that these were high-risk patients who were exposed to TDXD in the neoadjuvant and then post-neoadjuvant setting. So it's not necessarily going to be a strategy I think that everyone needs or we need to do for everyone. I do have to say I love the neoadjuvant aspect because it's a much more limited amount of TDXD we're giving, right? We're not giving a year of it, we're giving 4 cycles of it. And boy, if I don't ever have to give TCHP again, I would be thrilled because that is a very intolerable regimen for the vast majority of patients who are exposed to it.
And it looks like we're going to see more data from another neoadjuvant study, TDXD. Also, just to let you know that back to Jay in the chat room, he says the SP, thanks for your input. The SP142 is positive. He's going to try atezo in this patient, just FYI. Let's see if we can squeeze in one quick final case. This is from Dr. Rupert, a 78-year-old lady, again, ER positive, HER2 low metastatic disease. Progresses after only 1 year of riboletrozole. We were talking about time on CDK, very short time, ends up on sacituzumab. Here's Dr. Rupert.
She was started on sacituzumab govitecan in March of 2025, and she is still on that now. She's tolerated it pretty well. She had some mild cytopenias, but the lung mets became maybe a 40 or 50% reduction in size. Her cough has gone away. She had a little bit of pain with this chest wall mass, and that has gone away. And she feels like this is a miracle drug for her. Certainly for me, the sequencing of these agents is really confusing. And I'd be interested to know how you'd sequence the sacituzumab govitecan in a patient with metastatic breast cancer with receptor positive disease. I'm also curious, Neil, where's your endpoint? How long do you typically keep a patient on sacituzumab? Is it until resistance or intolerance, like with other drugs? Or do you hit a point where you back off and allow the patient to have a little bit of bone marrow recovery time? This patient was HER2 low. Would they consider trastuzumab deruxtecan in this case rather than the sacituzumab, or does the existence of pulmonary metastasis, would that make your faculty shy away from this out of the concern for interstitial pneumonitis or some other pulmonary toxicity of the TDXD? Another question is, we've had this recent FDA approval of Dato-DXd, and the question I have is, how would your faculty members choose between sacituzumab and Dato-DXd? Are there differences in toxicities?
So we talked about a few of these things. I just want to point out to another phase 3 trials that got about to get presented. It's not a ADC one, but I think very interesting related to ADC, specifically TDXD and the DB09 study, because now we have a study, HERCLIMB-05, where they're using, instead of trastuzumab pertuzumab after chemo, trastuzumab pertuzumab, they're adding in tucatinib. Dr. Hamilton's going to be presenting what we hear is a positive study. But getting back to this scenario that Dr. Rupert mentioned, Lisa, how long do you keep people on sacituzumab? And what about this issue of people with pulmonary metastasis? They may be symptomatic from that. Will you still treat a patient like that with TDXD?
Yeah, I mean, I think I think actually he gives a great story for continuing the SASI, right? Because she had what sounds like highly symptomatic disease, and all her symptoms went away and she feels great. So I usually don't interrupt. I think, Dr. Nanda gave a great example of a patient who wanted to go on a holiday and actually did very well. And I've had patients like that also. And I say, okay, you want to go on a holiday, we'll go on a holiday and we'll just monitor you carefully. But I don't do it routinely. And in this case, I didn't hear a compelling reason to put her on a holiday. What was the second question? Sorry.
Pulmonary Mets and ADC.
Yes. Boy, I get very nervous with patients with underlying symptomatic disease, either from their cancer or from other pulmonary disease and TDXD, just because they already, the tipping point for very serious complications is closer. So it's not that I won't give it, but boy, I try and reach for everything else first.
All right, well, I can't resist. One quick final question back to you, Rita, from one of our favorite oncologists, Karen Green. Are you ready to use TDXD in the neoadjuvant setting based on DB11, or are you going to wait and see NCCN guidelines, approval, et cetera? You want to do it now, Rita?
I would love to do it now, but I will need some guidelines to guide me. So I think maybe a little bit more follow-up data as well. But I am excited about the possibility, but I'm not using it currently.
All right, and I want to thank particularly the docs who presented cases. They were so appreciative. People are willing to kind of put out their treatments for us to take a look at. We really appreciate it. And audience, be safe, stay well, and thanks so much, Rita. Thank you, Lisa. Thank you, audience. Have a great night.
Thanks.
Thanks a lot, Rita.
Night.
Thanks a lot, Lisa. Have a good one.
Thank you. You too.